Our case study is of a 5-year-old female named Molly. Molly has right side hemiplegia due to cerebral palsy caused by a stroke in utero. She's currently receiving OT and PT weekly at an outpatient clinic, and she has difficulty with gross and fine motor skills using both hands. She wears an AFO on her right lower extremity, and she currently attends preschool and will be beginning kindergarten in the fall.
For the current evidence-based appraisal paper, our EBP question is for a 5-year-old female with hemiplegia, is CIMT or bimanual training more effective for improving bimanual use for ADL function?
We included 3 Level 1 articles in this appraisal. One of them was a systematic review, and the other 2 were randomized control trials. From these articles, we learned that both constraint-induced movement therapy and bimanual training are effective to improve bimanual use in children with hemiplegia, and we also learned that the improvements that the participants had were very similar using both of these therapy techniques. We also learned from one randomized control trial that bimanual training is much more effective in improving bimanual function than traditional occupational therapy is alone. We also included one Level 2 article that was a cohort study about constraint-induced movement therapy. And in this study, we learned that constraint-induced movement therapy is effective for improving bimanual use for children with hemiplegia, but it's most effective when used with younger children. And from this study, we learned that when a participant has a period of intense constraint-induced movement therapy and then a period of normal occupational therapy, sometimes regression can occur. No Level 3 articles were included in our appraisal because all of the articles that we found either compared constraint-induced movement therapy to bimanual training, or it compared one of those types of interventions to a control group. So there were no studies found that only had one group. We did include one Level 4 study that was a single subject design on a participant receiving constraint-induced movement therapy. And through this study, we learned that constraint-induced movement therapy is effective and that the participants' improvements were maintained even in a follow-up that was months later. Also, we didn't include any Level 5 or qualitative articles in our appraisal because even though clinical expertise and opinions can be very helpful, we were searching for quantitative articles that had statistics to back up our evidence-based question.
The clinical bottom line for our study was that CIMT and bimanual training are both equally effective in improving bimanual use for children with hemiplegic cerebral palsy.
The 4 databases used were Medline, OT Search, AJOT, and the O'Kelly Library. Our search terms included constraint-induced movement therapy, bimanual training, hand-arm bimanual intensive training, children, cerebral palsy, and hemiplegic. We also used a combination of these terms when needed. For example, constraint-induced movement therapy in children with cerebral palsy. Medline yielded the most relevant results, and we obtained the most articles for Medline and the O'Kelly Library.
The inclusion criteria for our appraisal included articles that were about cerebral palsy, had participants ranging from birth to 21 years old, included constraint-induced movement therapy, bimanual training, or both, were published in English, and had the full text available online, and we excluded articles that were older than 15 years. In our appraisal, we included 3 Level 1 articles, 1 Level 2 article, and 1 Level 4 article, totaling 5 articles.
Our first Level 1 article is a systematic review. The study was relevant to our evidence-based practice question as all of the studies in the review compared constraint-induced movement therapy and bimanual training. The studies included were done in a clinically realistic manner. 7 articles were included in the review, and all of which were some form of randomized trials. Out of the 7 studies that were included in the review, only 1 was considered poor quality, while the other 2 were considered fair quality, and the remaining 4 were good quality. This review showed that both constraint-induced movement therapy and bimanual training are effective in improving the function of the impaired arm. Constraint-induced movement therapy had a greater effect on improving the arm function of this affected arm specifically, and bimanual training led to more bimanual use.
The next Level 1 article that we included was a randomized control trial that compared CIMT and HABIT, which is hand-arm bimanual intensive training. This article was relevant to our evidence-based question because it compared the two types of interventions that we were searching for. The population is relevant to our case, and Molly would qualify to be a participant in the study. The treatment was appropriate. All participants received normal occupational therapy for 8 weeks and then were randomly assigned to either receive CIMT or HABIT for 2 hours per day, 6 days per week for 8 weeks. The evaluators were blinded, and both groups were very similar at baseline and were treated equally throughout the study. There were a couple of drawbacks to this study. The general intervention topics and plans were given, but treatments weren't explained in enough detail to accurately replicate this study without more information. So if we were to replicate this study, we would have to contact the first author to get more information about the study. There was also only a 2-month follow-up period, and ideally the follow-up period would have been around 6 months so that we could see the true long-term effects of the interventions.
This randomized control trial looked to examine the effects of HABIT on the affected upper extremities in children with cerebral palsy. The client does fall within the inclusion criteria of the study. The treatment is feasible because therapy is 3 hours a day. The study revealed that HABIT improves fine motor performance in children with hemiplegic cerebral palsy. Our Level 2 article is a clinical cohort study. The purpose of our study is relevant to our evidence-based practice question as it showed the benefits of constraint-induced movement therapy. The intervention was described in detail but may not be clinically feasible due to the amount of time the children were in intensive therapy. The children received at least one full treatment set of constraint-induced movement therapy, which was 6 hours a day, 5 days a week for 4 weeks. Some children received up to 3 sets of therapy. There was 4 to 40 months between the treatment sets. The last 2 to 3 days of each treatment set included bimanual therapy activities. All of the children made progress after the first treatment set. Limitations include the study taking place at one clinic and all of the children having parents that sought out for them to participate in the study and viewed this therapy as very important.
For the Level 4 critical appraisal, we used a single subject design study on CIMT conducted on a preschool-aged child. The study was relevant to our EBP question in that it looked at constraint-induced movement therapy and its effect on a preschool-aged child. The clinical intervention was realistic and would easily be replicated in our case scenario. Our case study client does meet the inclusion and exclusion criteria, and it is relevant to our case study in that she did meet the inclusion criteria of having 20 degrees of wrist extension and 10 degrees minimum of finger extension. The drawbacks to the study was that the therapist was not blinded, and there was only one therapist for the pre-test, intervention, and post-test, and therefore bias was not minimized. All of the studies in our BestBET paper include the use of CIMT or bimanual training for pediatric clients in their therapy intervention. The studies provide these interventions to pediatric samples similar to our case study patient Molly. The findings of these articles are very clinically relevant to the goals and interests of occupational therapists, such as improving coordination, movement, and functional ability to complete ADL tasks. These interventions can be used to treat patients similar to Molly interchangeably to best fit the activity that is being completed. Results of these studies show that CIMT and or bimanual training can be used in practice.
Based on the research, CIMT and bimanual training interventions can improve function of the upper limbs in children with cerebral palsy. These interventions can improve gross and fine motor movements while also developing strength and tone in the upper limbs. Occupational therapists should want to learn more about CIMT and BIM-based interventions. Therapists could obtain continuing education credits for attending presentations on CIMT and BIM interventions. Therapists could learn how CIMT works versus how BIM works. the pros and cons for both forms of therapy, and when it should be recommended for a client.
One question that is relevant to the research in the articles that we appraised for the current appraisal, and also one that was mentioned in some of the articles that we appraised, is that could CIMT and bimanual training be more effective when used together? So when we're looking at this, we would want more future research to be done to determine if CIMT and bimanual training would be more effective in conjunction with one another. And based on our EBP question, future research looking at the long-term effects of both interventions would be useful to determine the impact on the client's gross and fine motor coordination skills. This needs to be completed in order to determine not only the long-term effects, but which one is more effective during the therapy sessions, and especially when looking at fine motor skills, gross motor skills when completing ADL task. Does one of them have a greater impact on the client's functional ability?